Next speaker is Dr. Piyush Kapoor, who will be speaking on understanding of multifocal IOL to get the happy patient. Over to you, sir.
In my talk, basically, I'll be just giving an overview about how the multifocals actually work and how we can customize various multifocals, the whole lot available today, and get more happy patients in our surgery. So when we talk about cataract surgery, the IOL technology has really advanced, but loss of accommodation still needs to be captured. When we look at the conventional monofocals, we of course get a good distance vision. The near is gets compromised. Multifocals are associated with lot of glare and halos, but on date, most of the needs of the patient are the intermediate zone, the one which they are viewing at 40 to 60 centimeter, or like driving, shaving, and other activities which requires a range of about 60 to 80 centimeters. So, in order to understand and define the need, when we are looking at IOL, what as surgeons we need to look at is first as asphericity, addressing toricity, and targeting all our patients to be aimed less than a 0.75 of residual astigmatism when it considers as a cylinder, and being able to treat presbyopia to the maximum possible depending upon the patient's need and desire. The basic aim is to touch the normal physiology as close as possible. When we say this, is it so simple that we just implant and we say, yes, you are a happy patient and you can see all? And if I say yes for it, then why not multifocal for all? But my friend, it is really not that simple. And that's why we are not able to address multifocal to all our patients as of now. Looking into the real science of multifocal, there are various technologies available. One is the refractive platform, where we get two refractive foci out of the lens. Then is the zonal asphericity, which breaks down the refraction into such fragments that we get a continuous range, as is available in Minivel. Then is the diffractive platform, which mostly comes with the rings, lot of glare and halos, as it gives light splitting and gives much compromise in terms of contrast to the patient. And then the newer technology, the wavefront shaping, where we actually just prolong the foci and give a continuous range, where the glare and halos are much reduced and the patient gets better quality of vision. Looking at this animation, we can actually see that how the glare and halos actually come up. As we see in a monofocal, we get a classical single foci. But when it comes to bifocals, we generally get two foci like this, and the light the light which converges a bit interior for the near one gives rise to a glare and halos where the light looks spread scattered like this. So this is what a patient gets when he gets a multifocal classically implanted. Now, some people adjust, some are not able to. And then we look at the newer generation, the EDOF, which actually gives a continuous foci like this. It is as good as a monofocal, and the glare and halos are much reduced because we get a distinct foci, and the contrast, in fact, is also better as compared to the classical multifocal technology which we had in the diffractive ones. So, expanding the patient's horizon, we see that we have a whole plethora of lenses available in our kitty today. We have the XEDOX, we have the trifocals, we have the normal multifocals, we have the CRV lenses, and thus we can actually transform our cataract surgery to a true refractive surgery if used properly. But my friend, the punchline is that all these lenses, if you go back and see, work on one phenomenon that is called neuroadaptation. When we look at this picture, we can very well see a face, but when we look carefully, we can see two distinct people standing, a male and a female old man. And this is what is actually the neuroadaptation which the patient has to adjust to. Some people are able to adjust, and they are those happy patients, but some are not able to adjust, and that's why we need to be careful in our real patient selection. Now, how do we get this good patient and happy patient? My formula in this is the classical ABCD, where I look at the attitude and the astigmatism of the patient. I need to have a perfect bang on biometry. I look at the type of cataract, and I do not take up the patients with other pathologies. So, looking at the attitude, we classically aim or target the patients who are the happy go lucky types, who are ready to adjust with a little neuroadaptation, which they are positive on to adjust to it, and try to reduce your post operative astigmatism to less than a 0.75, or I would be more precise, less than a 0.5. Aiming a good biometry, I would say optical biometry in premium IOL practice is a must, but nothing less than an immersion works. Always, I give a word of caution to the patients with the classical polar cataracts and all, that we may or may not implant a multifocal, because if we land up with a rent or something and you cannot actually do a proper capture of the IOL, then a decentration may be more devastating than just saying that yes, I have implanted a multifocal. Diseases like this, where diabetic retinopathy and all, of course, interfere with the multifocal, so always avoid such pathologies. The next most important thing I would need to specify is recognize your lens. I say two P's play into it. One is the power play. You need to personalize your A constant. If you look at the various lenses which were being talked about, every lens has does not bang on work at the A constant which is theoretically described by the market or by the company people. I have generally seen that when we are implanting a synergy lens, I target a little hyperopia, but when I'm going in for an EDOF lens like the Lux Smart from Bosch and Lomb and Physiol, I generally aim towards a little myopic side, which comes up with an experience, and this is what I call as personalized A constant for a particular lens. And this gives you the real correct targeted biometry what you need for your patients. And the second P is the performance play. How does the lens actually work? How does it actually work for the patient? How happy the patients are? For which, talk to your colleagues and see your own experience by putting in the lens for a few patients who are more forgiving sorts, and which will allow you to understand that which lens works the best. Talking about the traditional where various multifocals are available, but how do we do it is we do the right patient selection, a proper counseling, good surgery of course is required, and thus you have those happy patients. Based on these visual requirements, the patients who really do not want any glasses, trifocals or the extended range of vision lenses are the one I choose for, and who are okay with a little dependency on the glasses, but they want a better quality of vision, of course, EDOF are the choice for it. Depending upon the lifestyle, if the patient is a night driver, I would always choose an EDOF, and if not much, trifocals and the extended range of vision lenses or the like the synergy and all are my choice. Astigmatism, as I said, less than a 0.75, I do not intervene, and I always place my incision on the steep axis. Anything between 0.75 to 1, I generally use my flax and use the LRI to correct it, but anything more than 1, always a toric is a must. Having eliminated all the major exclusions, I would say that almost any eye or any individual is actually suited for a multifocal or an EDOF if planned suitably. And patient satisfaction is actually directly proportional to your target emetropia. The near your refraction is close to zero, I say almost 100% happy patients you achieve. Thank you.
Thank you, Dr. Piyush Kapoor, for the nice presentation. We have in our next rescue team to the red coding cataract, Dr. Shital Madhukar.
I have a question, Dr. Piyush. So, in a unilateral
Dr. Shital is there with us?
a young patient with unilateral cataract who does not want ring and halos, what will be your choice of lens?
Of course, an EDOF, ma'am, and I would actually see that what sort of lifestyle the patient has. When you say a young patient who is actually
Around 40s
total 40s,
with lot
for,
of screen time.
again a hyperopic or a myopic. If you know a myopic, lot of screen time, she's okay with the glasses. I even look at what is the refraction. Like if the refraction is anything around a 1.25, she says she wants to use glasses, I can even use a EDOF on one side and allow her to be with the glasses. But if the patient wants to be absolutely glasses independent, then maybe, and if she does not have too much of night driving, then maybe I can use an ERV and do a LASIK on the other eye.
And out of the ones do you prefer? I mean, the
I
Lucidays
have been
and
using Physiol, I have been using Lux Smart, I have been using almost all like eye hands, everything. But on date, if I see that the best near vision I'm getting is with Bosch and Lomb Lux Smart, where almost with a binocular implant I get up to about an N6. Physiol generally gives a little less. The patient mostly requires a 1.25 to a 1.5, and eye hands, of course, I do not consider it as a EDOF. I always talk about it as a monofocal lens with a better near vision.
what about the Vivity?
Vivity, of course, is good, but I had been implanting lot of Vivity, but lately I have shifted my practice more towards Bosch and Lomb Luxmart, because I have seen that the quality of vision with Luxmart is slightly better. It does not come with any kind of rings. Like Vivity has those refractive rings. Some of the patients with Vivity do complain of a little compromise in their distance vision. When I was saying that neuro adaptation, like come what may, any EDOF you may talk about, any multifocal you may talk about, they have a little compromise in terms of the quality of vision, and how much the adaptability is there and how much that visual disturbance is there is variable from lens to lens. So Lux Smart is the choice when it comes to, as compared to Vivity in these days of my practice.
Thank you.
Great talk, sir. I agree with your, your comment about attitude. I think attitude is the most important. And if we could have some questionnaire where we could, a psychological questionnaire to figure out which patients are best suited for
We
multifocal.
do have, ma'am,
Yeah,
before any patient is counseled for a multifocal, he has to fill the form,
correct. Yeah.
and
So I just wanted
accordingly we
to like
just
stress the importance of that. Also, a question to you is that, there are some very few patients who persistently keep complaining about the halos and are unhappy. So have you, in your experience, had to explant and do an IOL exchange, or how do you deal with those patients?
ma'am, honestly speaking, I have only explanted the lenses of other doctors, because there I am like little aggressive कि okay निकाल देते हैं. But whenever it is my patient, I have always been conservative, and 100% I have seen that if I have given time to the patient, as long as maybe 3 months, or even make them wait up to 6 months, and if they have stuck to me, they all get settled gradually.
No, that I agree with. Yeah.
I think 6 months ideally.
Yeah, 3 to 6 months is the time that any patient, I believe, they adjust. The neuroadaptation plays. And lately we have even started a trial with these online softwares which are available for the adult amblyopia, the Revital Vision. And I have been starting some patients on those, because it has been claimed by the company that neuroadaptation comes faster in these patients. So Binox as well as Revital, like both of them. Revital claims it a little more. It is a US based one. So I have given it to about 3 patients of mine. But yet I have to get the response, because I just started about 6 weeks back.
Okay. Thank you so much.